Giovanna, I think we should start. You ready?
Go ahead.
All right. Welcome, everyone, to a continuing 2020 Population Association of America virtual style. Today we are continuing our approximately monthly series on COVID-19. And today we have a session that was organized and will be chaired by Giovanna Merli. This is one in a number of sessions that have been organized by a group including Sarah Curran, who will help with the questions today, Jen Dowd, Pam Hurd, myself, and Giovanna. So we welcome all of you. And at the end of the session, you'll hear about our next one in August in this continuing series. And this will again be on another international topic, as is the one today. So Giovanna, why don't you take over?
Thank you, Eileen. Good morning, good afternoon, or good evening, depending on where you are. Giovanna Merli from Duke University. The session title, as you can see, Insights on COVID-19 Impacts, International Comparisons and Possibilities. The idea of this webinar is to show how demographers and population scientists are using extant administrative or survey data, many of which are publicly available, to capture, highlight, and compare COVID-19 impacts and vulnerabilities across countries or population groups. I have a couple of reminders about this webinar. Each panelist will take 13 minutes maximum for their presentation. And after each presentation, there will be an opportunity for the members of the audience to ask questions with the chat option or the question and answer options. The questions will be read by me or Sarah Curran, who is here to kindly help. And the questions again will be asked after each presentation. Then at the end, if we have more time, we'll entertain additional questions. So and now to our speakers. Our first speaker, who has the honor of launching this webinar, is Patrick Heuveline from UCLA, who will assess the properties of 3 demographic indicators which rely on routinely collected mortality data for temporal and international comparisons. His presentation is titled Comparative COVID-19 Mortality Indicators and Early Assessment. Thank you, Patrick.
Thank you, Giovanna. Thank you for this opportunity to present our work. I want to begin by acknowledging my co-author, Mike Tzen, and Hiram Beltran-Sanchez, both of them also at CCPR, UCLA. To give you a little bit of background, sorry, I have a window to stop here. I started to work on COVID mortality somewhat unintentionally back in March because I was asked to review a number of COVID-related papers. I was finding myself repeating the same observation over and over, so I thought I would put them out there and wanted to illustrate them with actual data, which at the time were changing very quickly. So Mike Tzen developed a web scraping routine that allowed for updates of the results every couple of days. We put a preprint online in early May. But this work is mostly intended to non-demographers. So after introducing you to this quickly today, what I wanted to do is also to add a few reflections, maybe more geared towards demographer from work that Hiram and I are conducting more recently. So the first of my observation is that it's preferable, and we know this from back in the HIV AIDS days, when the disease is mostly asymptomatic for many people for a long time. It's preferable to track the pandemic with confirmed deaths and rather than confirmed cases. Confirmed deaths in the case of COVID might underestimate the actual number of deaths. from COVID. But if you look at excess deaths data from CDC, for example, it appears that reported COVID deaths account for about 80% of excess deaths in the past, in the recent months. Of course, excess deaths is not exactly, doesn't have to exactly match COVID mortality, but it suggests that it's a reasonable order of magnitude for COVID deaths under count, and that it is way smaller than the case under count, because if we again look at CDC data, the commercial labs or prevalence survey suggests that the ratio of that the confirmed cases might only be about 10% of the total number of cases. And I would also argue that death is a better metric for if we want to evaluate policies that were intended to, as we famously know now, flatten the curve, that is to reduce pressure on hospital ICU capacity and eventually reduce cumulative mortality rather than cumulative number of infection. My second observation is that it's preferable to work with rates than with ratio. It was quickly recognized that it made little sense to compare the number of deaths in, say, Belgium with 10 million and some, and the number of deaths in the US with over 330 million. But just dividing deaths by population size makes it difficult to compare COVID and other overall mortality, which we typically measure with crude death rate. And the difference between the crude death rate and this death per capita ratio is easy to miss when the CDR typically refers to 1 year, and we measure time in years. So this T in this equation for the CDR is equal to 1. But in the case of COVID, we're looking at deaths that have taken place over a much shorter period of time, months, a few months. And remembering that the time dimension in the CDR, the fact that it's expressed in deaths per person years, and then dividing the number of deaths by this fraction of a year in which the number of deaths were counted, actually makes it easier to compare COVID and overall mortality. So I've suggested to use this crude COVID death rate. The third observation, and probably the most important of everything I'm going to say today, is that you can age standardize even when COVID deaths are not tabulated by age. And it became very quickly clear that COVID mortality had a strong age and sex pattern, and that it would be preferable to sex and age standardize before comparing COVID mortality across population. But that is often stated in the limitation section of a paper, arguing that it could not be done because COVID deaths by sex and age were not available for the population of interest. This is an issue that many demographers will recognize. It's the reason Ansley Coles developed his index of fertility for the Princeton European Fertility Project, for example. And in mortality analysis, we have the comparative mortality ratio, which borrows an age pattern of mortality in a reference population here, and compares the number of deaths in the population of interest with the counterfactual number of deaths that would be obtained with those rates and the actual age distribution of the population. So in this case, I have used the age pattern that is published by the CDC. So it's the age pattern for the US. I've chosen it because it's the largest number of COVID deaths that have been that are tabulated by age and sex at the moment, over 100,000. And this comparative COVID mortality ratio, let's compare the level of COVID mortality in any population that has an age and sex distribution with COVID mortality in the US. This ratio can even be multiplied then by the US rate of COVID mortality to get an indirectly standardized, this is a product here at the bottom, indirectly standardized COVID death rate, which has a metric that is similar to the COVID death rate, or directly standardized rate, because it has the US population as a standard. And then for the age-specific death rate, it uses the rate of the US scaled up or down, depending on the value of the crude comparative COVID mortality ratio, and you can then get a number that is similar to a crude death rate. My last observation, my last suggestion was regarding estimation of life expectancy. This takes a little bit more data because it requires a previously projected life table for 2020, which becomes a counterfactual. And then it reverses the steps that I usually take to in demography to get an associated single decrement life table from a multiple decrement life table. So here you would use the pre-COVID-19 life table as the age-specific associated single decrement life table and add COVID mortality to it. If you're not familiar with the steps to perform this, I refer you to chapter 4 of your favorite textbook. The advantage of using this metric, of course, life expectancy is very intuitive. It's a number of years as opposed to a number of deaths per person years lived. It's age standardized, so it's appropriate for comparison across population, and historical time series are often available so that you can actually also compare COVID mortality with with previous public health crisis. So now the second part of the presentation, I would like to turn to some reflection on using these traditional mortality indicators, specifically for the study of COVID mortality. The first piece of good news is that indirect standardization really works in the case of COVID because age-specific patterns tend to be fairly comparable across population. We have now age-specific data on deaths, COVID deaths from all US states and from a number of European countries. And if you compare the directly standardized, the unstandardized death rate, the blue bars here, to the directly standardized rate, the gray bar here, you see that in the middle, the orange bars are the indirectly standardized rates, and they do capture most of what direct standardization do. So they're very close. And so indirect standardization is really a good option, especially when you're dealing with small population for which data might be not tabulated or not very reliable by age and sex. The second thing that works as planned is this comparison of the crude death rate from COVID to the crude death rate from all causes combined. Here you see the trend from the state of New York over time, and the flat line is a crude death rate for the state in 2017. So of course, this comparison ignores any seasonality in overall mortality or an annual trend, but it does show that the overall, for a period from mid-March to about the end of May, COVID deaths exceeded deaths from all the causes combined. So these rates work pretty well for this COVID, the crude COVID death rate works well for comparison with overall mortality as intended. The graph also shows though that it's limited to, it doesn't work very well for comparing rates across population because there's a strong duration dependency in this rate. So adjusting for the length of the period on which deaths are being counted is not enough to make this comparison meaningful unless population experience the onset of COVID at roughly the same time and they are roughly the same stage of the disease diffusion. The same way that adjusting for the size of the population is not really enough to make a comparison really meaningful between populations that are very different in size and density. Here's the crude COVID death rate for the US, this red line. And here you can see this red line here, again, compared to other countries that started pretty much at the same time as the US to experience COVID mortality. And here again, the red line is the US. And from this graph, you may infer that the US rate is not very high, and especially compared to Belgium, which is at the top in the purple line. And also, we can observe that its post-peak, if there's any peak around here, decline is very slow, even slower than in Sweden. And we know that Sweden has taken a very different approach to mitigating the effect of COVID, which may explain it in the case of Sweden. So, but this international, I would argue this international comparison is still misleading because of the different sizes and densities of population involved. And to illustrate this point, this chart compares Belgium, the yellow bar in the middle here, again, the highest rate for any countries with 5 larger countries in which I also pick with the same color a subnational unit to show the a subnational unit that is much closer in size, population size to Belgium. And to illustrate the point, I won't go over all of this, but I think the best way to drive my point is probably to compare here Mexico, the country, with Mexico, the state, and Mexico, the city state. So what I'm getting here to is the impact of heterogeneity. My slide title is a little nod to my colleague over there in Rostock. So comparing the trend in the US with the trend in other countries is tricky because the epidemic in the US is a sum of different epidemics across different states and cities. And here we can see the trends from the 10 largest urban counties. On top again is New York. Taking New York out of the picture makes it a little bit easier to see the trends in the other cities. And so what we see is, New York is peaking sometime in April, Chicago and Philadelphia are peaking sometime in May. There's hardly any peak in LA. It's been flat for the last 2 months, essentially. And even more worrisome in Phoenix, we see that it seemed to be trending down and trending up again. So what I'm arguing is that the distincting trend in the US is partly the result of being the aggregate of those different local trends. And however, those trends cannot be treated as fully independent either from one another. And going to an always smaller scale is not necessarily the answer or the best way to study the dynamics. So there's more to say on this, but I'd like to get to my last point, which is on life expectancy, and with a somewhat of a warning, the fact that there's a lot of things to love about life expectancy as a metric, but it's we have to remember that the decline in life expectancy are typically small. So the recent opioid overdose epidemic, for example, only reduced life expectancy by 0.3 years. The larger drop in the US was 0.3 years in 1992-93. So the fact that, for example, if we use the University of Washington projection, COVID might reduce 2020 life expectancy in the US by something like 3/4 of a year. It's far from negligible, but it may seem trivial to many non-demographers that are not used to these orders of magnitude. I had a little bit more to say, but I think I'm out of time. So I'll give the floor back to Giovanna.
Thank you, Patrick. Now we have 5 minutes for questions, and I see there are 2 already, so I'll go ahead and read them. And please do feel free to enter your questions either through the question and answer or the chat box. So the first question is by Philip Cohen. Does the indirect method assume the age distribution of COVID deaths are the same as in the US?
Yes, the answer yes. And what I was meaning to show you with the comparison with the direct and indirect standardized death rate is that this assumption seems to be a pretty good one, because when you use the actual death rate age pattern in a country, for the European country for which they're available, and you compare to the indirect method where you make that assumption, the results are very close. So yes, this is a fairly good assumption in this case. The age pattern seems to be fairly stable, at least across European countries and US states.
Philip says, thanks, got it. The next question, as someone living in Behar County, San Antonio, the trend has shot up recently as cases have spiked enormously. Surprised by seeing such a flat trend. I was mapping this early on, and this is a question by Lily Kazura.
Okay, so the flat trend, I think we might be looking at different things. So the crude COVID death rate that I'm arguing is an average. So that is an accumulated average of deaths divided by the length of time. So it's going to have more inertia than a daily death rate. So it's possible that it's quite, and I believe you're right, and that the number of deaths daily is increasing. It's going to take, if it's above the historical average, that is since the first death, it's going to start to pull the crude COVID death rate up, but it's going to react more slowly. And you could see this as a disadvantage. It doesn't react as quickly. It has some advantages too, because it doesn't have this daily up. We know that the number of recorded deaths go down on Sunday and go back up on Monday. So it depends what you're looking at, but it's you can see that even if you look at Phoenix, for example, in that country, even the average COVID death rate is going up, has been going up recently. So I agree with you. There are some disturbing trends in the Southwest recently.
The next question is by Saida Batol. What about the highly populous countries with low mortality rates, but low tests and low recorded deaths?
I'm not sure. I mean, you may be referring to large countries like India, for example, that have low deaths per capita ratio. They also have accrued fairly low rates at the moment. What I would suggest, I think, as I was showing on one of the slides, is to, in those large countries, it does make sense to go down to a lower level. First subnational, the state, or maybe even the county. I was mentioning this. It's a really difficult question to find the right level. When you are at the level of a state, you always probably benefit from going lower down. But if you go to local states, you ignore the fact that some of these epidemics are actually interrelated, and you cannot quite study them in isolation. So I hope that answers your question. I'm not sure I got it exactly.
Okay, do you see any other questions, Sarah?
Yes,
don't.
there's one here in the chat. Does heterogeneous population affect COVID-19 cases? I'm not sure. Let's see. Does the rate or ratio appreciate? I'm actually not sure. It's in the chat.
So what you have in the case of every epidemic that diffuses, when the population is separated into groups and that are heterogeneous and somewhat distinct, so they don't have a strong, a lot of contact, that will sort of average down and reduce the diffusion of the epidemic on the average. And I think this is what's happening partly in the US, but as we mentioned with the first question, I'll show you on the slide, this is not the only explanation for the US. It's partly the explanation why the US was at a slow level, at a low level, and that's partly the explanation why it doesn't seem to decline as quickly as elsewhere. But that's not the only reason, because if we look at at some particular counties in the Southwest, we can see that indeed the epidemic is picking up again.
Okay, I'm afraid we have to go to the next speaker. There will be an opportunity at the end to continue asking questions from any of the speakers. So the next speaker is Daniela Perrotta from the Max Planck Institute of Demographic Research. And she will present results from a continuously run Facebook survey on COVID-19 induced attitudes and behaviors across 8 countries. The title is Behaviors and Attitudes in Response to the COVID-19 Pandemic, Insights from a Cross-National Facebook Survey. Daniela, it's up to you. That's your floor.
Yeah. So hi, everyone. Good evening from Germany. And first of all, thank you for having me here. This is my first PAA event ever. So thank you for the warm welcome and for the invitation. So today I will present some insights from our Facebook survey data, focusing mainly on behaviors and attitudes we observed in our population sample in response to the COVID-19 pandemic. And first, a few words about our survey. So we developed our survey called the COVID-19 Health Behavior Survey as a rapid data collection and continuous monitoring system of people's reactions and response to the pandemic. And we designed our questionnaires in a way to cover a broad range of topics, including social demographic questions, health-related indicators, attitudes, behaviors, and so on. We started the data collection on March 13, actually at a time when the need for timely behavioral data was critical for capturing potential changes in behaviors, rapid adoption of preventive measures, as well as compliance with governmental actions. And we first started the data collection in Italy, United Kingdom, and United States. And then we extended it to France, Germany, and then Spain, the Netherlands, and Belgium, allowing this way the cross-national comparison across countries at different stages of the epidemic and with different control strategies in place. So for our survey, we recruit participants via Facebook advertising campaigns, which allows us to quickly reach large and diverse samples of respondents in an environment that is super flexible and somehow controlled for targeting and recruiting respondents from specific subgroups of Facebook users, and also for dynamically reallocating the budget to reach a desired audience. And here in this picture, you can see an example of an advertisement shown to Facebook users in the United States, so that when they click on the ad, they directly jump to the questionnaire. As for the data protection, the participation is anonymous. We don't collect any personal identifiable information. And for this study, we received ethical approval from the Ethics Council of the Max Planck Society. So in this study that you can find it online in form of preprint on medRxiv, we considered a time period from March 13 to April 19 for a total of over 70,000 completed questionnaires. And since online surveys are generally, online data are generally biased due to self-selection and non-representativeness, somehow this is true. So we oversampled, as you can see here, we oversampled female respondents, as we know that women are generally more likely to engage with health-related content, like, for example, surveys, blogs, and so on. Our respondents are mainly adults aged between 25 and 64 years old. Instead, we found a little bit more difficult to recruit participants among the younger age group and among the elderly, probably because of different usage of Facebook or a lack of interest in a health-related survey, probably among the younger. So to address this issue and to correct for non-representativeness, we use a post-stratification weighting technique, which allows us to reweight our survey data on the general population. And in particular, we use as post-stratification variables the age, sex, and region of residence of respondents, so that in this way we can at least approximate the general population in the central demographic variables. So first, we analyzed the threat perception posed by COVID-19, as we were particularly interested in capturing the impact on different demographic groups. So we asked our respondents to rate the the perceived threat posed by COVID-19 to different levels of society, ranging from the threat to themselves, to their family, to their local community, to their country, and to the world. And here I'm showing results that are weighted and normalized between 0 and 1. Where 0 means very low threat and 1 means very high threat. And to get a sense of what this actually means, we asked exactly the same question, but for the threat perception for influenza, in order to have like a sort of baseline for a well-known infectious disease, which actually causes regular annual seasonal epidemics every year. And we find that the perceived threat for COVID-19 is on average, from 40 to 50% higher than the threat for influenza. And this is not surprising given the novelty and uncertainty surrounding COVID-19 and the lack of a vaccine. What we can also observe here in these two heat maps is this clear pattern in threat perception, increasing from a more personal from a personal level to a more national and global level. And in particular, considering the threat perceived globally, this is almost 50% higher than the threat perceived personally. And this can be somehow an indicator of how people perceive the risk of complications following an infection from COVID-19, and consequently engage with protective behaviors and adhere to recommended measures like social distancing. And going deeper, we can also look into the threat perception by age and sex. And here I'm showing the relationship between the threat perceived by male respondents on the x-axis and the threat perceived by female respondents on the y-axis to different levels of society indicated by the color code and across the different levels, across different age groups indicated by the size of the points in the scatter plot. So here we can observe several interesting patterns, right? First of all, we see it is more evident this pattern, this increasing pattern in the threat perception from a personal to a national and global perspective. And secondly, we see how women are more concerned than men. They perceive a higher threat compared to men, except for the age group 65 plus, for the threat perceived to themselves and to their family. And lastly, we can also observe how younger people are less concerned about COVID-19 and perceive a lower threat compared to older people, except for the perceived threat to their family. That is more evident here in this plot below, looking at the age distribution between the threat perceived to oneself and the threat perceived to their family. So here it is clear how younger people perceive like a moderately low threat for themselves, but then this is significantly higher for their family. And instead, older people, like older adults and the elderly, perceive a similar concern, a similar threat, both for themselves and for their family. So overall, what does it actually mean? So this clear pattern that we can see in this data in age and sex are somehow relevant for is like an indicator of the level of awareness and concern in the population and consequent efficacy of communication campaigns. So the fact that younger people perceive a higher threat for their family and older people perceive higher threat for themselves actually means a strong communication campaign, given that we know that older people are at highest risk of severe complications following an infection from COVID-19. So another aspect that we can measure with our survey data is the uptake of preventive measures, and that's super important because we know that individual behavior is one of the key factors in shaping the course of epidemics, and this is so. When we think about individual behaviors in situations like when the mortality is high or when the threat perception is high, individuals tend to adopt to change their behaviors and adopt more protective, preventive behaviors to protect themselves in order to reduce the likelihood of transmission and infections. And this is particularly relevant for policymakers, but also for designing more realistic epidemic modeling approach to explore a variety of possible scenarios and to project the potential trajectory of the epidemic. So in our study, we cannot really capture the changes in behaviors at the individual level, given the cross-sectional nature of our study, but we can measure the adoption of preventive behaviors across the socio-demographic groups and over time, trying somehow to disentangle those behaviors that are more spontaneously adopted, like the increased hand hygiene, from those behaviors that are enforced by non-pharmaceutical interventions. And for example, here in this plot, we can see high compliance to social distancing that was first encouraged and then ordered in most of the countries, and somehow reflected also in the reduced use of public transport following lockdowns and stay-at-home orders. On the other hand, instead for more spontaneous, let's say, behaviors like wearing a face mask or increase in hygiene, this is more reflection of individual awareness and strong communication campaign. And it's particularly interesting looking at the trend for wearing a protective face mask that we can see here. So in this observation time, the observation period, the wearing a face mask was not mandatory yet. So, and then was rapidly adopted in most of the countries, especially in Spain, France, Italy, and the United States, mainly among the older age group and among women. So this is a clear example of a rapid change in behaviors in the population, given that all these countries had no previous history of wearing face mask in public. And on the other hand, instead looking at the increased hand hygiene, we observe instead a fairly constant trend over time. We observe no significant difference across age groups, and again we observe how women are more likely to adopt preventive behaviors, and this is again relevant for policymakers, as we know that the case fatality rate for COVID-19 is higher for women than for men. And so one might expect that men are more concerned about it and more likely to adopt preventive behaviors to protect themselves. And instead, in our study, we show that this is not necessarily true, as we see that women are more perceive higher threat and are more likely to adopt protective behaviors. So I think I'm running out of time, but I wanted to conclude with 3 key messages from my presentation. So first of all, we've seen how Facebook advertising allows us to quickly reach large and diverse samples of respondents, maintaining the data collection over time. And even though those data are somehow biased, we can adjust for it using a post-stratification weighting approach to try to approximate the general population. And secondly, having this cross-national comparison is important to capture differences across countries at different stages of the epidemics and with different control strategies in place. And lastly, so conducting this kind of rapid online service can be critical, provide insights for policymakers to design more effective and stronger communication campaigns. And yeah, thank you for your attention and looking forward for your comments and questions.
Thank you, Daniela. And there are a few questions for you, which I will go ahead and read. I should also say that a few more questions went unanswered because of lack of time for the Patrick presentation. So we'll, keep them, move them to the end. So the first question for Daniela is from Vijay Kumar Mishra. And that is, sort of a question that I'm sure many are asking when when we are collecting data with Facebook survey. And so he's asking, what's your view on the reliability and validity of surveys done through Facebook? And in particular, could you please explain more about the post-certification weights?
Yeah, so thank you for your question. This is really a good point. And actually, we are now looking into that because it's super important to address this issue of reliability and accuracy of Facebook data. So what we do in for targeting the Facebook users, we use the same variables as we use for the post-stratification, so age, sex, and regions of residence. So we have the information from Facebook where Facebook think or somehow infer where people live, their sex and their age, and then we have the answers from our survey, the exact same answer, and we can measure how reliable is Facebook, at least in these three variables. And instead, for the second point, for the post-stratification weight, so we use these three variables, age, sex, and regions of residence, and basically we reweight the proportion of participants, proportion of respondents that we have in our survey on the true population counts of the general population in each county, so that in this way we can give a bit more weight to those groups that are underestimated, and give instead more weight to those groups that are overestimated. The other way around.
All right, so thank you, Daniela. The next question is by Marine Khan, who's asking whether the threat perception control for cases, or deaths at the country of origin at the time of the survey. So does the threat perception control for deaths in the country of origin at the time of the survey?
No. So the short answer is no, we are not controlling for that.
I have a question from Irma, if you want to take a minute. I have a question.
Okay, go ahead.
Irma Ilo asks, did you collect any information on education or other measures of SES? And if so, did the results vary by these factors?
Yeah, so we do collect education level as well as the work status, employment, and actually I do have a plot. But so what we see is that when we post-stratify using these three variables, and we look at the distribution of the education attainment in the countries, the results that we obtain on the weighted sample is not that far from the one of the general population in most of the countries. So even though we don't use this variable to control for non-representativeness, then the sample is not that far from the general population, at least for the education level. We haven't looked into the work status, for example.
I think the question was, just quickly follow up, it wasn't about the distribution, but it was about the impact of SES on the results, on perception.
Yeah, no, we haven't looked into that. And yeah, just to follow up, our respondents are mainly educated respondents, so, but we haven't looked into that. That's actually a good point, thank you.
And maybe you want to copy into the chat for the audience a link to the study, because I know that there are a few questions that I cannot read because we are running out of time, that may are particularly interested in looking at the data you collected. But the last question, very quickly, by Simona Bignami. Did you ask if the individual or any of his or her family members had been tested for COVID-19?
Yeah, so we do actually ask this question, and if they say yes, we also have a follow-up question asking if they tested positive. But overall, like the sample who was tested was very small, and yeah.
Okay, I'll leave the rest of the questions for the end. And I want to transition to the next speaker, who is Dean Lillard from Ohio State University, who will talk about a cross-national design to estimate the effects of the policies and the information environment induced by COVID-19, using harmonized data from ongoing household panel surveys across 10 countries, including the panel study of income dynamics in the US. Thank you, Dean. Go ahead.
Okay, well, thank you very much. So I'm actually not going to talk about any results. I'm going to talk about a design of something that we've proposed and to make people aware of data that are going to be available for people to use. And it's a collaborative effort of people in 10 different countries. You can see the list of people here. All of them are connected by one unifying thing, and that is that except for Sweden, there's a household-based panel survey that's been conducted or either for many, many, many years, in the case of the United States, more than 50, or in the case of Italy, for 1 year. But they all use a very similar design, which is the design maybe you're familiar with in the panel study of income dynamics or the German socioeconomic panel. So it's an everlasting following rule, which means that the base sample is followed and all descendants of the base sample is followed. And so when we were thinking about as a group, so the project started immediately us talking about how can we collect data and what questions are going to be asked in each of the surveys. The natural organizing element was to take advantage of the significant variation across countries. And at the same time, the commonality in the design of the surveys that are generating the data that we want to study. So I'm going to go through these points relatively quickly because I only have a few minutes, and the slides will be available online. And of course, you can send me questions as you like. So I don't need to spend much time trying to motivate why people should be considering cross-national comparisons for studying questions related to the coronavirus. These are some of the things that many people have already mentioned and that are major determining objects that we're interested in, both from a scientific and from a policy perspective. But the thing that makes this particular question or this particular topic interesting is in working on cross-national topics, it's really, I think, important to have some common underlying process that gives at least some plausibility to the idea that we should observe the same thing in every population. And so because COVID's a disease and because we're all human, we make the assumption that there's a common underlying biological process. And then all the interesting social science that we're going to study comes out of the fact that both from either individual perspectives, as Daniela was talking about in terms of people's responses to the threat or the perceived threat of COVID, or because governments chose to act in different ways at different times, gives us then this possibility for doing all kinds of interesting studies. And I'm going to come back to a point that Daniela made and that Patrick made, and that is that in fact, if you are trying to study the direct experience of COVID, either as an infection, a death, or the death of somebody that you know, it's not very likely. So I'll run through a few slides that are very similar to what we've already seen. This is demonstrating there's a lot of variation in cases across countries. This is just taking the accumulated cases on each day, adjusting for the population, but a little bit different than what Patrick did. It's benchmarked to the first day that the case count per 100,000 population was bigger than 1. So it's trying to adjust the fact that some countries started later in the disease and some countries started earlier. So there's a lot of variation in the case counts. As Patrick has already alluded, there's lots of reasons not to trust these data. There's lots of differences about how countries test, whether they test, who they test, but there's huge variation. There's less variation in deaths, and the ordering of the deaths is much different. And of course, it's very similar to what Patrick showed in the first presentation. But again, these are things that provide variation. And one participant already asked whether some of the perceptions that were being measured in the Facebook survey used as a control the number of deaths that were in the country. And so that's one of the things that we're also interested in. what I want to make the point is, if you're thinking about using existing surveys, or even if you're doing a survey that like the one that was just described, you're not going to get many people when you do that survey. This is the count per 100,000 population. A more reasonable sample size is 10,000 populations. So you can see in the second and the fourth column, the number of people that you would expect in a random sample if COVID was distributed evenly across the age distribution. And even in the United States, which has the highest case count, 100,000 or 10,000 people randomly sampled, if COVID was evenly distributed, would only generate a sample size of people who actually were tested or experienced COVID is 100. If you look at deaths, it's even smaller. And so the overall risk that any individual in a random sample is going to have experienced COVID, been infected with it, or experienced a death from COVID is very low. And so because it's very rare, we, as an object of study, the direct experience of COVID needs to use aggregate data. If we want to use survey data, one of the things that we can do is we can understand, or try to understand, how people reacted to the policies that governments implemented. And there's a long list of policies. In the thing that we're doing, in the project that I'm describing, we're choosing 11 countries using panel data or pseudo panel data. We're going to model it in a very standard framework where we can take the whole history of policies sort of dated back, because all of these panels that we're talking about are repeated panels of the same individuals, in households and in relationships. So we can, at each year, and you can too, in all of the surveys that I'm going to describe, they're publicly available. So you can take the sample that's produced this year or next year or in 2 years, and then take the policies going back in time and try to study outcomes like being laid off, being furloughed, income, partner formation, domestic abuse, fertility decisions, household composition choices. And so that's some of the things that we're going to be studying. And our basic data are coming from household-based panel surveys that are listed here. And a project that I've been running for many years, together with many of the people on this list, harmonizes those data so that they can be made more directly comparable. So we have a subset of the variables from all of these surveys where we've reworked the data and put them on the same conceptual basis, use the same response categories, measured over the same time period, so that people can then estimate models without having to worry as much about differences in the underlying data. So the new Italian study, for example, was in the field when COVID hit. It had to be suspended, but they've started back up. And so their first year of data from this panel study, the Italian live study, should be coming out sometime this year or maybe early next year. And then we have a project that we've proposed to create comparable data from the China family panel studies. And we really wanted to get Sweden into the sample because of the very different mitigation policies that Sweden was following. There aren't many cases that sort of are outliers in terms of policies. And so Martin Carlson has been working with Swedish administrative data for many, many years. And he's, if we get funding, will going to create panel data from administrative data that matches the structure of all of our household panels. And what I mean by the structure is each of these panels measures people from the same household who eventually form their own independent households. So the PSID has representatives in the sample from 4 generations. We're going to mimic that in the Swedish administrative data. When we construct the administrative data, we're going to deliberately pick people who are related by blood and marriage, but live in different households so that we can try to mimic the structure of the other panels. We've standardized the domains that you see with common variable names and response categories. That makes it easy to write your models and sort of talk about results. So just to give a preview, in the run-up to this project, one of the things that we talked about was whether or not each of these surveys is going to be asking a specific set of questions related to COVID, and they all are. The next slide is going to give you some overview. So look on the left-hand column. Here it's showing the topical modules that each of the partners is planning to implement. The ones in green are the ones that are definitely planned. Many of the topics are asked in their core survey, and not all of them are going to be asked at the same time. So here, the UK Household Longitudinal Study already has data available. I will put up a slide next that shows the website where you can go download those data and look at the questions. The surveys in yellow are already in the field collecting the data. So on their next release, these data are going to be available. And then the surveys in green will be going into the field early next year with collecting these questions. And so I mentioned before, the UK HLS did a very innovative special survey. They're going in monthly and asking questions to their sample. They're releasing the data immediately. So there's now 2 waves, two months of data that are available. The survey for May is being processed, sorry, April and May are released. June is being processed and about to be released. And you can access the data at this website. So those data are already available. And many of the things that you can do with these data is you can compare long run trends for people who have been in the panel for many years before this experience. So I highly recommend that people go there. So the advantages of using the policies is that everyone's treated in different ways. We're going to be spending a lot of time on sort of measuring the timing of the policies. The strengthening of the policies, loosening and repeal gives lots of potential variation for this that we're going to match then to the panel members. If our project is funded, we're going to make these policy data available. And there are of course many projects out there that are sort of tracking policies in different countries. The one thing that's different here is we're going to drill down to the lowest level of aggregation that we can, because in many countries like the United States, but even in Germany or in Italy, there were local policies that differed from the national one. It's challenging. Here's a list of challenges. A lot of the effort that we're going to be putting into our project is sort of addressing these challenges. Just to give a simple example, this is from an NBR working paper that came out in March. There's high degree of correlation between the implementation of different policies. So when a government put in a social distancing policies, they simultaneously put in cancellation of public events. And so you can't get much independent variation for some of these policies, and we'll be thinking about that. So let me just quickly summarize and then answer any questions that people might have. It's important, we think it's important that as social scientists and as population scientists, we think about what we can learn using existing survey data about this experience. And so because governments tried to address many aspects of the health side of COVID, of this pandemic, we can take advantage of those policies to study what happened on the economic and social side. And that's important to try and inform what's going to happen in the future should we, God forbid, have this experience again. But we need to contribute a better understanding of all the different dimensions that occurred through this experience. So with the panel data, it gives us a chance to benchmark on long run averages, follow people through time. We know the sampling probabilities, we know the characteristics of the sample, and so we hope to contribute this to social science. So here you can find more information about the cross-national equivalent file. And you can check every now and then to see where we are in this project if you want to be using our policy data. Thank you.
Thank you, Dean. And I wanted to mention to those people who have asked for the presentations, they will be posted, the slides will be posted on the PA website soon, sort of at some point soon after this webinar. So I'm trying, there are many questions, so I'm trying sort of to parse through. I think there is one question that you've already addressed in the rest of your presentation, Dean, but it may be worth asking again, so that you can clarify, is from Mori Kamara. Would it not be too soon to speak of an impact study of COVID-19? To talk about an impact study, we need a lot of time and observation in the future. For now, we could still talk about short-term influence.
Absolutely. I mean, one of the things that we have to confront is what is exactly are we trying to measure? Of course, there's short-term impacts. And if you look on the UK data, there's already a working paper that's sort of documenting what the short-term impacts are, the distributional impacts of some of the government mitigation policies. It's very uneven. So in terms of creating inequalities, the government mitigation policies more severely impacted people with low education, people whose jobs could not be done at a distance. And so in terms of income losses, in terms of having to be socially isolated, there was a huge distributional impact. The interesting thing about it, and the reason that I think that these panel data are so interesting is there's lots of reasons to expect there to be long run effects. So maybe you've read articles or you've seen observations or people making conjectures. The educational attainment also has a huge distributional difference. People like some of my colleagues on this are well educated, they've got computer, they've got good access at home, they could do online schooling of their children and provide expertise and tutoring for their children. That wasn't the same for parents who didn't have a good home connection for electronic or for distance learning. Maybe they weren't so familiar with the computer, so when something went wrong. And so there's lots of questions about how this is going to be reflected in earning or educational trajectories next year and the year after and the year after that because of the cumulative aspect of education. So.
Okay, then the next question is by Elizabeth Thompson, who's wondering how tightly policies are connected to the behaviors that may reduce transmission. Will you be including data on actual changes in travel, use of public transportation, etc.? So
the survey the surveys differ in terms of some of those things. There's not much on travel, but we do ask, there are going to be questions asked about health behaviors and about preventive measures that people took to reduce transmission in almost all of the surveys.
All right, I'll have a couple of questions about data quality, mortality data quality, but I'll keep them to the end, so they pertain to both presentations by you and by Patrick. We'll transition to the final. Thank you very much, Dean. Yep. I know you have to leave soon, but hope you can stay with us for as long as possible. The last presentation is by Emily Wiemers, who will, from Syracuse University, who will present on disparities in vulnerability to severe complication from COVID-19 in the United States, with analysis of extant data from the panel study of income dynamics. Thank you, Emily.
Thanks so much. Okay. This is joint work with colleagues at Duke and also Michigan and UCLA. Sorry, I just wanna, here we go. So we know from what we've learned so far, that the presence of pre-existing health conditions increases vulnerability to complications from COVID-19. We know this from the CDC, where 90% of hospitalized patients have at least one pre-existing health condition. And some studies out of New York City suggest that the median number of pre-existing health conditions was around 4. Hypertension, diabetes, obesity, and cardiovascular disease are among the most common conditions. And in the US, this vulnerability to COVID-19 based on pre-existing health condition collides with longstanding disparities in health and mortality by race, ethnicity, and socioeconomic status, especially in midlife. I mean, we need to understand how to translate what we know about disparities more generally into vulnerability for complications from this disease. And we know something about these disparities already from surveillance data, which shows disparities, mainly race ethnic disparities in infections, hospitalizations, and deaths. But of course, this data has limitations. We're missing race ethnicity for some of the cases in the surveillance data. The coverage is limited. There is lags in the data that includes health conditions. And I think most importantly for what we're working on, there's nothing on differences by socioeconomic status, by education, or by income. And so that's what we're gonna try to look at today. So this paper leverages a machine learning model that predicts the likelihood of inpatient hospitalization to previous respiratory infections using Medicare and healthcare systems claims data based on the pre-existing conditions that individuals have. This model we take from DiCaprio et al. 2020. And we combine this with nationally and population representative data from the panel study of income dynamics, where respondents report their SES and also health conditions. And we use this then to estimate the relative vulnerability to severe complications from COVID-19, which we call VI, the vulnerability index, for adults in the PSID based on their pre-existing health conditions. And we focus on disparities by race, ethnicity, education, and household income, and how these vary by age. So I'm just going to tell you a little bit about what I'm going to show you. I'm going to show you two things. One is just the distribution of the number of pre-existing health conditions, which I'm going to call risk factors because it's shorter, by race, ethnicity, education, and income. And then I'm going to show you the median vulnerability index, also by race, ethnicity, education, and income, and age. And as I said, this index is derived from a machine learning model which predicts hospitalizations with a severe respiratory infection, not COVID-19, based on age, gender, and individuals' pre-existing risk factors. So for each individual, it measures the odds of hospitalization from a respiratory infection relative to that for a 30-year-old woman with no risk factors. And so then we just take what we find for each individual, and we take medians by groups. So first I want to tell you a little bit about the risk factors. So this figure shows the marginal contribution of each risk factor in the DiCaprio model that's available in the PSID and how it contributes to vulnerability index by age. So the first thing at the bottom, you can see which pre-existing conditions are covered in the model and also in the PSID. And then you can see that for some conditions like hypertension and lung disease, these are important and their sort of contribution to your risk grows with age. Whereas other factors like asthma, which is kind of a dotted blue line, is sort of important at younger ages, but doesn't grow in importance of predicting hospitalization much with age. So you can see from this that there are factors, which factors you have matter, how many you have, and also how old you are going to contribute to our estimates of how vulnerable you are to hospitalization based on your pre-existing conditions. And I should note, there's a couple risk factors that are not included in the PSID that are in the model, the machine learning model. So in some sense, what we're estimating is an underestimate, but all of the sort of big factors are included in the PSID. All the big factors in the model and the CDC risk factors. So we applied this model then to the 2017 PSID. The PSID is useful for a couple reasons, some of which I'll come to at the end, but for our purposes of looking at disparities, it's useful because it has a large oversample of Blacks and low-income families as part of its original study design in 1968. And then in 1997 and in 2017, immigrants who had come to the US after 1968 in the case of 1997, and after 1997, in the case of 2017, they were added to the sample. So we use a sample of household heads and their partners who are age 25 and older, who have information on all the things we're interested in: age, race, ethnicity, educational attainment, household income, and pre-existing health conditions. And I should say that the item non-response in the PSID is extremely low. So we end up with an N of around 13,000 people. The one thing I want to point to in the descriptive statistics of the sample is just the age distribution of the sample. This is a point, again, that I'll return to, but that's also been noted by other people. There are differences in the distribution of age across groups. So in particular, I want to highlight the age differences by race ethnicity. Whites are older on average than non-Hispanic Blacks and the Hispanics. 28% of whites, non-Hispanic whites, are 65 and older, compared to only 17% of non-Hispanic Blacks and 13% of Hispanics. Those with less education are older than those with more education, and those in the bottom household income quartile are also older than those in the top household income quartile. And this is important because, as we've discussed several times already, there's a strong age gradient to adverse outcomes, including hospitalization and death from COVID-19. So I'm going to start by just showing the distribution of the number of risk factors by our race, ethnicity, and age. And what you see here is that if we compare non-Hispanic whites to non-Hispanic Blacks, across every age group, non-Hispanic Blacks have more health conditions than non-Hispanic whites. In midlife, nearly half of non-Hispanic whites have 0 health conditions, and about a quarter have 2 or more. Whereas for Blacks, less than a third have 0 health conditions, and over 40% have 2 or more health conditions. Hispanics in midlife are healthier, and younger ages have fewer health conditions than whites. Over half in midlife have 0 health conditions, and less than 20% have 2 or more. This figure shows the same distribution of the number of risk factors by education, and you can see here that those who have more education have fewer risk factors than those with less education, and this is true across all age groups. And finally, I'm going to show you the same distributions by household income. And here you see quite stark differences in the distribution of risk factors. By midlife, less than a third of individuals in the bottom household income quartile have 0 health conditions, and over a quarter have 3 or more. Individuals in the top household income quartile, about half of them have 0 health conditions, and only 5% have 3 or more. So now I'm just going to show you how these health conditions translate into vulnerability to hospitalization from COVID-19. So this shows the median VI by race, ethnicity, and age. And I want to start with the far right bars, which show the median vulnerability index for all individuals 25 and older, for non-Hispanic whites in yellow, non-Hispanic Blacks in blue, and Hispanics in gray. And what you notice is that the median vulnerability for non-Hispanic whites and non-Hispanic Blacks is the same. This is, again, their vulnerability based on pre-existing health conditions. And overall, Hispanics are about 40% less vulnerable to hospitalization based on pre-existing health conditions than non-Hispanic whites. But you see, if you look within age groups, in every age group, non-Hispanic Blacks actually have a higher median vulnerability than non-Hispanic whites. In midlife, non-Hispanic Blacks are 86% more vulnerable than non-Hispanic whites. But as I pointed to the importance of the age distribution at the beginning of the slides, or the beginning of the results, the fact that whites are older on average than Blacks, and so many more of them are in this category of people 65 and older, means that on average, over the entire population, they face the same median risk based on their age and their pre-existing conditions. In contrast, Hispanics are less vulnerable at younger ages. In midlife, they're 24% less vulnerable than whites, and that corresponds to less vulnerability based on age and pre-existing conditions in the population overall. When we look by education, we see that for those 25 and older, those with a high school degree or less are 1.6 times the risk of those of a college degree or more. And in midlife, they're 40% more vulnerable. And finally, by household income, we see very large gaps in vulnerability based on age and pre-existing health conditions. For the total population of those 25 and older, those who are individuals who are in the bottom household income quartile are nearly 3 times as vulnerable as those in the top household income quartile. And this gap emerges and is very large by midlife. So just to kind of contextualize what we're finding, we've tried to compare our measure of VI with something that we know about patients hospitalized with COVID-19. So one thing that we've done is we've taken data from the CDC on the sort of distribution of pre-existing conditions among hospitalized patients, and we've tried to estimate a VI for that population. And what we find is that indeed these patients are vulnerable according to our index. For those 50 to 64, they're in the 65th percentile of vulnerability overall, and for those 65 plus, they're in the 84th percentile vulnerability. But I think everyone has probably noticed that we find that in real life, we find much different and much larger disparities by race ethnicity than would be predicted by pre-existing health conditions and age. We see, startling gaps in hospitalizations where non-Hispanic Blacks are much more likely to be hospitalized than whites, both overall and age adjusted. And despite the fact that based on their pre-existing health conditions and age, we don't see them as more vulnerable. And also Hispanics are more likely to be hospitalized both overall and age adjusted, despite the fact that their pre-existing health conditions and age would put them at lower risk. And so obviously disparities in exposure are really important here. And so one thing that's really great about using data from existing surveys like the PSID or the HRS or at health data is that we can think about exposure really quite broadly. We know a lot about the things that people do in their daily lives. We know where they live and who they live with. We know where their families live. We know where they work and what jobs they work in. We know where their kids go to school. We know lots of things about them. And so that allows us to sort of think quite broadly about understanding disparities in exposure based on the sort of accumulation of all the factors that play into people's exposure overall. And so that's some of the next steps that we're working on now. So thanks very much.
So thank you, Emily. I have one question in the chat box from Maury Kamara, which is, could you explain about children? Why are they less at risk?
So we don't include children in our study. We're looking just at adults age 25 and older. I think children are really important, but I don't know, I'm not sure we know enough about what puts children at risk from adverse outcomes to sort of use the PSID to estimate that, but also the health conditions are not collected for children. So, well, some are in the child development study, but in the core for adults, it's restricted to heads and wives, so.
Yeah. I don't see other questions here, but I might miss it. So if someone wants to raise their hand, they could.
Yeah, I have not seen any also, though there are a few questions for a couple of the other panelists that I didn't want to miss before we wrap it up. We still have.
Here's one, I have one. Yuri Francis, which how does hypertension or diabetes matter regardless of whether they are receiving or under treatment with drug support? Like, how do you take into account
so
that?
we haven't, because the model that we're sort of applying to the PSID doesn't take that into account, but as we know more and have better models that predict what health conditions affect hospitalizations, this is something that you can apply because we do know things from the panel studies about the extent to which these diseases are controlled. So that's a nice thing. As we know more, we can learn more from applying what we know to nationally representative data.
I have another one from Vijay Kumar Mishra. could you be more specific about which machine learning algorithm you've used, clustering NLP, DBS-CAN, or anything else?
We didn't use any. We use someone else's model. Again, I think part of the reason I'm here is to sort of say that one thing that's nice is that you can apply different people's models to your data. And the reason that we use the model that we did is that it's based on pre-existing health conditions and not clinical diagnoses as people enter the ER, which you wouldn't have in panel data, right? So we used one that is applicable to the kind of data that we have. But yes, there are lots of different things that you could apply to what you know about people from panel data.
I have a couple of questions for the previous panelists, if you are ready to go on to those, unless there are any other questions for Emily.
We have one from Rafael Lopez Vega. I think it's how would pre-existing health conditions by ethnicity, what do you know about the Mexican immigrant population and COVID-19 impact?
Yeah, so I think that obviously different studies are going to be able to break down different immigrant groups differently. In the PSID, there's not enough Hispanics to break into different groups, but there are studies where that is true. And so there you could look at sort of the prevalence of certain disease conditions across groups and look at differences within Hispanics. Yeah.
Thank you.
All right, so one question that was asked earlier that Patrick certainly could address is by Sonalde Desai, and who's asking, in countries where death registration is of poor quality, will we ever get good COVID-19 mortality estimates outside of the censuses?
Yeah, yes, thank you. And I think it was also the first question that the question about large country that I misunderstood was actually about incomplete death registration. So this is, of course, a big problem. I only can reflect on my experience working with HIV pandemic, that I remember there was some sample death registration that was used, sample approach where people try to determine the cause of death on a sample of deaths by going to local morgues, basically. I think there was a paper by, I think it was Annabelle Degré-Doulou at INED who did the study in Dakar. Might have been other. The other thing that was useful for HIV was ANC antenatal clinic seroprevalence survey, but this is not likely to be a very good tool in this case because of the age range at which most of people have severe, have COVID infection. But that would be probably another approach would be to have a somewhat a nationally representative seroprevalence survey, and then try to derive rates of serious cases and then fatality rate from those.
And another question, both, any of the panelists, but certainly Patrick and Dean, given their presentations. What is your view on estimation of deaths or cases per 100,000, considering the non-randomness of confirmed cases or deaths? The non-randomness of confirmed cases of deaths or deaths.
I'm not sure I understand the question. I mean, I'm at the national level, you have countries with good data for which you don't have, I don't think you have much randomness. You have fairly close to full account. And, but I don't know the situation in other countries. There are probably countries where we have large parts of the population that are not covered, but I have no particular knowledge of this.
Any other questions?
Maybe Dean, you want to chime in?
I mean, I agree. I think the one observation is that there's a wide variability in who got tested and when people got tested. So, for example, speaking with my colleagues in South Korea, they said it would be impossible for them to get a test, to get tested for for coronavirus, because the government at the time was restricting the testing to people who had symptoms. And so that hasn't changed much. So even now, people can't go and privately get COVID testing. I guess maybe they can in South Korea, but certainly they can at health clinics. So in terms of confirmed cases, there's huge variability across countries. And I personally agree with Patrick that excess deaths is the way to think about it. And the one observation that I would add to what Patrick has shown is the excess deaths is also going to include the deaths that are caused by not the coronavirus, but by the policies themselves. So the unemployment is known to lead to greater suicides, to greater opioid overdoses and things like that. And so all of that's embedded inside there, but still excess deaths are a much better measure than cases.
Any other questions, Sarah? My internet connection is going in and out. I could not sort of identify new questions, but towards the end, there are a lot of questions and panelists answering in the question and answer, which is hard to track. Regardless, we are 5 minutes from the end of the session, and I think Eileen has something to announce, but I would like to thank everybody for this excellent, the panelists for these excellent presentations and the lively questions from the audience. And again, everything will be posted, slides and the recording of the presentations online on the PA websites very soon. So please, Eileen, thank you, everybody.
And thank you very much for Giovanna for organizing what was really an interesting and lively session. And Betsy, will you put up the slide since on the next session? Betsy? All right, the next session. There. Pardon me?
She's probably getting there.
Yeah, okay. So, the next session is going to be on August 18th. And again, it is focusing on international issues, and it is organized by Sonal Desai, and she will chair the session. And she is doing this as the head of the PAA International Outreach Committee. This session is going to be slightly earlier. It's 11:30 Eastern time. So people on the West Coast need to organize themselves before earlier that day. But that's because we're, again, we want to make it a little bit easier for people, at least in Europe and maybe Asia, to actually attend the session. So, and in closing, I would say that we are continuing to organize these sessions through the end of the year. So if people have suggestions for things they'd like to see in webinars on COVID-19, make your suggestions to members of the committee, which, as I indicated before, is me, Sarah Curran, Giovanna Merli, Jen Dowd, and Pam Hurd. So we thank everybody for today's session, and we look forward to seeing you next month. Thank you.
Goodbye, everybody. Thank you very much.